Laboratory values for the older adult, Iowa Lakes Community College. This is Martha Olson. When we look at the older adult, we think about how the laboratory values might be a little different based on liver and kidney function. As the liver and kidney function changes or declines with aging, we know that the laboratory values obviously will be very different. BUN and creatinine are higher in the older adult that has kidney problems. Their hydration status and the change in fat versus muscle in the older adult can affect some of the laboratory values, as well as circulation, atherosclerosis, diabetes, that they have changes in circulation or metabolism. When we see older adults that have changes in hormones or their metabolism can affect some of the laboratory values that we see. With delirium, we want to make sure that we find the underlying cause for that. Is it a situation with hypoxia or CO2 retention causing changes in their mentation? Bladder scans, do they have a bladder full of 1,000 milliliters of urine and that's causing them to be changing their status and being very confused? Underlying infections such as UTIs or pneumonia are very common in older adults and can show up with changes in their mental status. And sometimes undertreated pain is also considered something we need to assess for. What MOC calls delirium labs are listed here. You want to run all of these, including the folate, magnesium phosphate, do a toxicology. Are they taking too many of a medication and they're toxic to it, or their digoxin? Are they toxic to that? And then check a blood glucose. Your vitamin B12, your pernicious anemia, we think of that also can cause some changes in mentation. With depression, we want to rule out things like hypothyroidism, so getting your laboratory values, your T4, T3, TSH for checking the thyroid. Neurological disorders like a stroke need to also be looked at because those little TIAs or mini strokes can show up and appear like it's a depression for the older adult. Again, we're going to look at metabolic panel, your B12, folate, and get a UA. I would say most of the time a UA is always indicated for the older adult, just because so many times that UA can tell us what is being eliminated, how is the kidney working, are they having infection or red blood cells in that UA. And then lastly, you might see an MRI of the brain being ordered as well. As far as malnutrition, we want to look at albumin and pre-albumin. Remember, albumin takes about 20 to 25 days to change if the person is not eating, having issues with digestion or absorption. And so the albumin might be 20 days out before we see a change in that. The pre-albumin is going to show changes much sooner, and then looking at the cholesterol might also help us to identify some issues with malnutrition, and then finding the underlying cause of that. Is it due to dentures and teeth, swallowing, dysphagia? Perhaps they're getting some dementia and they're just forgetting to eat. With urinary incontinence, many times when I worked in the clinic, the nursing home would call and say, can we run a UA up on Mabel because she's just not herself, she's a little more confused. And when we ran the UA and we found that underlying UTI or other problem, it was much easier for the doctor or the healthcare provider to order the Bactrim or antibiotic that they needed and get them started on that. And that was a very good way for communication and also taking care of the urinary incontinence, finding the underlying cause of that. With the urine culture, remember, we're going to look for the bacteria that's growing, and so at least a midstream clean catch. If you can't get it that way because of incontinence or other issues, you'll probably have to do a mini cath to obtain that sterile specimen. With colon cancer, we want to be looking at those occult screenings where we use the occult tester to look at is there blood or hidden blood, is what occult means. Remember that red meat can give a false positive result, and so you want to make sure that that person has had 2-3 days without red meat in their diet before doing the occult screening. Remember to use the middle of that bowel movement to get the sample, because the outside might have some blood from possibly like a hemorrhoid or just a little bit of tissue damage. And then if it turns blue, it is a positive and you need to let the doctor know. And usually we do 3 of those just so that we can kind of rule out false positives. Congestive heart failure, we're looking at our digoxin and diuretics as the typical treatments for that, but we also want to look at electrolytes, because with the diuretics it pulls that potassium and some of those other electrolytes out with that increased urine output. So we want to watch for hypokalemia. With digoxin, we want to watch your dig level, which tells, are they therapeutic, are they within that good window of being therapeutic with their level. And then look at your heart and rhythm changes, listening for a full minute. Is our heart strong and regular? Possible hooking them up to telemetry to look to see, is that heart rhythm changing as a result of the electrolyte changes that we see from the medications for congestive heart failure. Older adult that has confusion and infection, we've talked about getting the UA. We also want to look at that white blood cell. You know, early sepsis identification is vital to increasing their chance of survival, because there is a very high mortality rate with sepsis, and your older adult with the pneumonia and the UTIs being 2 of the infections that are high for causing sepsis. The neutrophils, remember, will elevate and tell you that it's a bacterial infection. Our eosinophils are elevated with allergic reactions, and then the monocytes, remember, are bacterial, but they are the slower moving cells that come in later to kind of help the neutrophils when they are running out of ammunition. Our neutropenic precautions need to be reevaluated. Make sure that you're up to date on those. Remember, no fresh flowers, no fresh fruit in a room where their white blood cell count is very low, and they would be high risk for getting an infection from their caregivers from the things coming into their room. We think of the cancer patient needing the neutropenic precautions, but there are many other times when neutropenic precautions are very much indicated for the older adult. Urinary incontinence can be a sign of infection, so again, get the UA, make sure that we're looking at the types of incontinence. Do they need to drink more water? Do we need to get them to the toilet on a regular basis and have the staff working with them to help prevent that incontinence, because it can cause, besides a lot of psychological issues, it can cause a lot of skin breakdown and other barriers for the older adult. The dehydration is a consideration and a very serious matter with many adults, older adults, because they cannot tolerate the dehydration like a younger person. When they have vomiting and diarrhea, they get the flu, they will need to be hospitalized sooner to get IV fluids and get rehydrated, because they cannot tolerate that like the young person. Remember, hemodilution and hemoconcentration. When you're overhydrated and they have a lot of fluid on board, it's going to be hemodilution, and your lab values may reflect that in looking very low, when in fact they're just in a huge pool of blood and they look low. Same thing when a person is very dehydrated. You're going to see those lab values actually looking very elevated when they're not. It's just a matter that they're in a very concentrated pool of blood and they look like they're high, but once we get an IV in and get them rehydrated, those levels then should return back to a more normal looking lab value for us. And so think about checking blood sugar, because the stress of dehydration on that older adult can cause them to have hyperglycemia. Even though we think they're not eating, they've got vomiting and diarrhea, the blood sugar should be low. It usually is high as a result of the stress on the body and that sugar coming out of the liver to kind of try to compensate. And then your specific gravity is going to give you a good indication of if your interventions are improving. Is your nursing interventions and the physician's orders of, the IV and the hydration improving? And so we look at that specific gravity to help us identify the hydration status for that older adult. As we look at chest pain, we know that your typical woman will come in with more of an indigestion type of chest pain, and your man usually comes in with more of a crushing chest pain, pain down the left arm, easier to identify. With all patients, no matter their age or their gender, we need to make sure that we're getting cardiac markers. We've missed a lot of some of the chest pain and MIs as a result of the indigestion type symptoms, so when you see cardiac markers being ordered, it just helps us rule out that that isn't what's going on. The hemoglobin that's low can cause chest pain. Remember, your person that comes in with a hemoglobin of 7 or 8 might be having chest pain because you're not getting enough oxygen to that myocardium due to the low hemoglobin, low oxygen getting to the cells. So there are other things that we need to look at. So with chest pain, you will hopefully see a hemoglobin and hematocrit level ordered as well to help us rule out anemia that could be causing the chest pain. Bleeding and anemia, then your GI bleeds, colon cancer, leukemia. We can have anemia from just malnutrition for a variety of reasons, need to be looked at because the bleeding can then lead to excuse me, anemia. When we look at the breakdown of the cells, we want to look at what type of anemia is happening. Is it a normal color and normal size? That would be a hemorrhage or bleeding because the cells themselves are normal. We've just lost too many through blood loss. So normocytic is your MCV, and that's the size of the cell, and normochromic, chromo is Greek for color, and that's your MCHC, and that's the color of the cell. Is it a nice deep red color? The arthritis, we would want to look at what type of arthritis. Is it a rheumatoid or osteoarthritis? And then look at some of the lab values that go with that. Your SED rate, telling about the amount of inflammation in the body, is going to be helpful in identifying the status of that arthritis. Treatment for RA is very different than osteoarthritis. RA is more of your anti-inflammatories, warmth to the joints when they're very painful and stiff in the morning, and rest for those joints. Stretching and strengthening is going to be part of that. Osteoarthritis is usually your weight-bearing joints, and we oftentimes will see weight loss recommended, as well as a joint replacement surgery to help that older adult to maintain their mobility without the pain to the hip or the knee that's causing them a lot of problems. So these are just some of the lab values that we think of, and some of the disorders or diseases that we see in the older adult that might prompt us to look at some of the lab values that go with the older adult and some of their comorbid conditions. I hope this was helpful in your study of the older adult. Thank you.